Welcome dear students, I am Dr. Pratyusha, and in the previous video we have learnt about the various types of rehabilitative methods and about conventional hearing aids. In continuation to that, let us learn about the next type of hearing aids, that are bone anchored hearing aids, in short called as BAHA, bone anchored hearing aids. These are based on the principle of bone conduction. I have told you initially that we have air conduction type of hearing aids and bone conduction type of hearing aids, and BAHA are bone conduction type of hearing aids. They are based on the principle of bone conduction. Now, in whom are these useful? They are suited to people who have conductive type of hearing loss and people who have unilateral type of hearing loss and those with mixed hearing loss, that is both conductive as well as sensory neural hearing loss, but they cannot wear in the ear or behind the ear type of hearing aids. Okay, let me write down the indications for you. First, it is based on the principle of bone conduction. And for whom is it used? It's used in people with conductive hearing loss and mixed hearing loss, but they cannot wear, but not suitable for behind the ear or in the ear type of hearing aids. Okay. Now, these bone anchored hearing aids, I'll tell you briefly how they work. We do a surgery and surgically implant this device so that the sound is transmitted by direct conduction through the bone to the cochlea. We are bypassing the external ear as well as the middle ear, the pinna, external auditory canal, tympanic membrane as well as middle ear. None of them need to be functional for BAHA because it directly stimulates the cochlea via the bone. Okay, it stimulates cochlea via bone, bypassing external ear as well as middle ear. Can you tell me a few conditions where this is possible? We have also discussed that in the previous video. Yes, any atresia of external auditory canal as well as pinna anomalies and deformities in people with crocea, anosia, or any unsuitable pinna that is not picking up the sounds or that is not allowing hearing aids. In all those conditions, BAHA is very useful. Okay. Now, this entire apparatus has three main parts. Okay. What are the three parts? First one is a titanium fixture. Titanium is very much compatible to the body. It's a non-reactive type of material. Okay. The second part is titanium abutment. And the third part is a sound processor. These are the three components, a fixture, an abutment, and finally a sound processor. Now, this fixture is surgically embedded in the skull bone. Okay, a surgery is done and it is embedded in the skull bone. The abutment, the next part, titanium abutment, is left outside. It is exposed outside the skin. So, we have the abutment outside and the fixture is placed inside. Now, this titanium fixture bonds with the surrounding bone tissue and that process is called as osseointegration. What is that process called as? It is called osseointegration. What does it mean? It is integrating with the bone around it. What is integrating? The titanium fixture that we have placed in the skull bone. And how long does this process take? It takes about 2 to 6 months. On an average, say 3 months. After 3 months, you will call the patient to look into the process. Okay, and once osseointegration is completed, then what we do is, already the fixture is present and abutment is also present. It is lying outside, exposed outside. We attach a sound processor. After osseointegration is complete, then we attach the sound processor. What happens now? This BAHA device transmits vibrations to the external abutment, which will further vibrate the skull and the cochlea. That's how the cochlea is stimulated and the patient can hear. Is this clear to all of you? The entire mechanism, all the 3 parts? Okay. Now, in whom is BAHA used? What are the indications and who are the right candidates for putting this BAHA? Okay. First, patients who have chronic inflammation or infections in the ear canal, who have discharging ears. When they have discharging ears, they cannot wear the standard in the ear or in the canal or behind the canal type of hearing aids. They cannot use air conduction type of hearing aids. Even if you think logically, we are bypassing the entire external ear as well as the middle ear. That means there are some problems in those 2 parts where BAHA is used. Okay, so what could be the first problem? There is ear discharge. Continuous ear discharge. And why will ear discharge be there? Because of chronic inflammation or infection. Making it impossible to wear hearing aids, air conduction type of hearing aids. Then second candidate profile is people who are using the conventional type of air conduction hearing aids will have some complaints. I told you one complaint is excessive feedback. What is excessive feedback? That whistling beep kind of sound that comes because the ear molds are not appropriately fitting, or because of excess wax in the ear or some malfunctioning in the entire device. So they face some problems, and putting hearing aids can also cause discomfort to some people. When they want to go for something better, instead of using the conventional type of hearing aids, we use BAHA. So one problem is feedback effect of conventional hearing aids. Or some discomfort with conventional type of hearing aids. As we have already discussed, children who are having malformed or absent outer ear and middle ear canal problem is there, such as external auditory canal ectasia, or some pinna anomalies such as microtia, anotia, etc. In all these children, BAHA can be used, because you don't need an external ear apparatus for this. Yes? Okay. Then in conductive or mixed type of hearing loss and some specific conditions such as otosclerosis or tympanosclerosis, where surgery cannot be performed. When you can't perform surgery, we will go for hearing aids. When surgery is contraindicated, we go for hearing aids, and in them, which type of hearing aids? BAHA is most suitable. And then for unilateral type of hearing loss, one ear is having problem, single-sided hearing loss. So let me quickly revise all the indications. One is when air conduction type of hearing aids cannot be used, such as when there is canal atresia or external ear pinna deformities, or when there is chronic ear discharge, in all these conditions. And if the patient is having any trouble with the hearing aids, such as feedback mechanism, and also because they are having some discomfort using the hearing aids. And then otosclerosis and tympanosclerosis if surgery is contraindicated. And finally, single-sided hearing loss. These are the indications for bone-anchored hearing devices, hearing aids. Now, while discussing the type of hearing aids, I told you about this one peculiar thing called as binaural with a Y connection. Now, like that, there is this thing called contralateral routing of signal, CROS. What is CROS? Contralateral routing of signals. In single-sided deafness, earlier this CROS was used, wherein we keep the hearing aid on one side and the receiver on the other side and connect them. Yes, but that is having many problems, and BAHA is much better than CROS. So earlier the CROS was used, it is not being used now for single-sided deafness, unilateral hearing loss. BAHA has replaced this CROS. Okay, because CROS has certain complications, complaints, and also BAHA is aesthetically better. Is that clear? Now this BAHA device can be implanted on the side of the deaf ear, and it transmits the sounds by means of bone conduction to the opposite side cochlea. In people with unilateral hearing loss, if we keep BAHA on that side, say suppose they are having sensory neural type of hearing loss also, cochlea is also damaged, then what we do? We connect BAHA, but internally it is connected to the contralateral cochlea. So, the sound is picked up from this side, but it is sent to the opposite healthy cochlea. That's how BAHA can be used in people with unilateral type of deafness. Is this clear? Now, what is the advantage with this? There is something called as head shadow effect. What is head shadow effect? Now, suppose you are hearing a sound from this side. With which ear can you hear it better? This ear or this ear? Same side ear, isn't it? What happens when you hear it with this ear? Suppose I say I close this ear and a sound is coming from this side. By the time it reaches this ear, either in front or behind the head or through the head, there is some amount of sound that is lost. Around 6 decibels is lost. That is called as head shadow effect. Did you all understand the concept of head shadow effect? Yes, the head acts as a barrier for sound to reach the other ear. So in patients with unilateral type of deafness, what happens is, if we use some device also, the sound which is coming from this side, on the side of deafness, this head shadow effect comes into play and the sound amplitude is reduced by the time it reaches the opposite ear. Now when you put BAHA, the receiver, the sound microphone is on this side only. So when it is picking up the sound, it is picking up sound from the same direction. Suppose sound is coming from this side. BAHA is put here, so it picks up the sound from the same direction and transmits it to the cochlea without this head shadow effect. Without any dampening of the sound, it nicely transmits. So we can overcome the head shadow effect also by using BAHA. Is this clear? Now this will improve the speech recognition in quiet as well as noisy surroundings. That is the advantage of BAHA. The speech recognition becomes better. It's much better than the CROS, contralateral routing of signal type of. Now let us see how this is placed. A surgery has to be performed. Surgery has to be performed. And how is this surgery done? In adults, it is a single step surgery. Whereas in children, it is a 2-step procedure. Let us see what they are. In adults, what we do is, we perform the surgery, integrate the titanium fixture in the skull in the mastoid region, wait for 3 months and then connect the sound processor. But in children, 2-stage is recommended, 2-stage procedure is recommended, wherein in the first step we put the fixture. It will take 6 months in children for osseointegration to occur, and in the second stage In the second step of operation, we connect the abutment through the skin to the fixture. The abutment is not placed in the first step. In adults, the fixture plus the abutment is placed in the first step and later the sound processor is just connected. But in children, only the fixture is put and after 6 months, then we put the abutment and then connect it to the sound processor. Is this difference clear to all of y'all? Okay. Now let us look into the complications of BAHA. What are the possible complications that can occur? Generally, it's a safe procedure. Very few complications occur. And some things that you can very relevantly think of are when you're putting an implant, in the implant site, some local infection or inflammation can occur. That is one possibility. Local infection or inflammation at the site of implant. Second complication that can occur, it occasionally occurs, that is, when we put a fixture, it has to osseointegrate. I told you there is a process called osseointegration. This osseointegration might not happen in a few people. That is another complication that can occur. Failure of osseointegration. So this is about bone-anchored hearing aids. I hope you've got a clear idea as to in whom we have to use, what is the procedure, what is the mechanism in which it is acting. It's very, very simple. If I have to tell you just in one line about BAHA, I'll tell you it picks up sounds and directly stimulates the cochlea via bone conduction. In unilateral deafness, it can stimulate the contralateral cochlea also. Is this clear? So we are bypassing the entire external and middle ear. Complication, surgical procedure, everything is very simple, isn't it? So this is about bone-anchored type of hearing aid. Now let us move on to the next type. The next type is implantable middle ear hearing aids. What does the name suggest? That we are directly stimulating the middle ear, sending sounds into the middle ear. They work on something called as direct drive principle. What is this direct drive? Rather than delivering the sound energy into the external auditory canal, the way we do it in conventional hearing aids, directly the middle ear is stimulated. The implant system is connected to the middle ear where the sound energy is converted into mechanical vibrations and we try to vibrate the ossicular chain. The external ear is not touched, it is left completely open. Now in hearing aids, I told you there is the microphone, the amplifier and a receiver, and finally that entire system is connected via a hearing aid which is sitting in the external auditory canal. But here you don't need the support of external auditory canal. We are directly connecting this entire instrument to the middle ear. Now when we are connecting to the middle ear, what is essential is the sound energy has to be converted to mechanical vibrations. Because the middle ear takes mechanical vibrations. Sound energy is converted to mechanical vibrations and middle ear ossicles are stimulated. Is the mechanism clear to all of you? Okay. Now this middle ear implantable devices are of two types. What are the two types? The first one is piezoelectric devices. And the next one is electromagnetic devices. Piezoelectric and electromagnetic. Now let us briefly see how they work, each of them, okay. Now piezoelectric devices, they work by converting electrical signal to mechanical vibration. Now in the entire system of sound amplification, what we are doing, the microphone will collect sound energy, it will convert it into electrical energy, and then the amplifier will amplify it, and receiver will again convert the electrical energy back into sound energy. But here we do not want sound energy. So what we do is, we do not convert electrical energy to sound energy. Instead, we convert this electrical signal into mechanical vibration. That is the concept here, and that is done by this piezoelectric device. How? We pass electric current through something called as piezoceramic crystal. That is a device, piezoceramic crystal. Now what will this piezoceramic crystal do? Whenever electric current is passed to it, it changes its shape. That is the speciality of piezoelectric crystal. Piezoceramic crystal. It changes the shape, and when it changes its shape, it creates a vibratory signal. That is our final goal, right? To convert electrical energy into mechanical energy, mechanical vibration. Now when this piezoceramic crystal creates a vibratory signal, that signal is transmitted to the ossicles of middle ear, and then the ossicular chain will vibrate and the normal physiological hearing process occurs. Malleus will stimulate the incus, and from incus to stapes, oval window, and then the inner ear is stimulated and sound perception occurs. Piezoelectric devices are highly sensitive. They can produce a wide range of frequencies, and they are also very, very small. So you can nicely implant them inside with minimal disruption to the ear. Okay, but it is slightly challenging to implant them. Electromagnetic devices are relatively easy. On the part of the surgeon, to learn to implant piezoelectric devices, for you as a doctor, is slightly complex to implant them, okay. But nevertheless, they're very, very good. They're highly sensitive and they're very, very small. But the problem with piezoelectric devices is, they are affected by outside temperature and humidity changes. That's the problem with piezoelectric devices. And their performance gets affected, and some people experience some sort of discomfort or irritation at the site of implant. Okay. See, all of them have some advantages and disadvantages, so we have to consider all the options that are available and finally decide based on the individual's needs. We have to discuss it with the patient also and finally take a decision. I hope you have understood how piezoelectric devices work. Okay. Now let us look into electromagnetic ones. This works on the principle of electromagnetic induction. What do I mean by that? Electric current is passed through a coil, and now this coil will generate magnetic field. This magnetic field will interact with the magnet that is attached to the ossicles. Let me write that down for you. It's not as complex as you think. There is an electric current. In piezoelectric devices, there is a crystal that is changing its shape and producing vibrations. It's very simple. This is also very simple. When current is passed, what happens is, through a coil, the current is passed through a coil, and that will generate a magnetic field. And you have put a magnet in the ear ossicles, attached to the ear ossicles. And any changes in the magnetic field, the magnet will move. Yes? When the magnet moves, magnet attached to ear ossicles vibrates. And when this vibrates, what happens? The ear ossicles will also vibrate, and sound is transmitted to the inner ear. Ossicles vibrate, and sound is transmitted to inner ear. Is this clear? But these type of electromagnetic devices are less commonly used than piezoelectric devices, okay? But they are also quite effective in improving hearing, but they are used in certain specific patients. What is important is you have to understand the mechanism. Broad principle in both of these, we are stimulating the middle ear ossicles and we are converting the sound energy into electrical energy and electrical energy into mechanical vibrations. Is it clear? Okay, now there is something else called as vibrant sound bridge device. Vibrant sound bridge device. In short, it is called as VSD. This is a semi-implantable device. It has two components, okay? Two components. What are the two components? One internal component and one external component. Okay, let me explain what this is. In the internal component, there is something called as vibrating ossicular prosthesis. That prosthesis has three parts. It has a receiver, it has a floating mass transducer, and there is a connection between these two parts. I'll write that down for you, don't worry. The internal part is called as vibrating ossicular prosthesis. VORP. Okay. This VORP has three parts. What are the three parts? One is a receiver. Then there is something called as floating mass transducer. FMT, not forensic medicine and toxicology. Floating mass transducer. And there is a conductor link between receiver and floating mass transducer. It is connecting these two parts. That is the internal component. Okay. Now how this works is, this floating mass transducer is directly connected to the incus bone. The middle ear ossicle incus is connected to this floating mass transducer. Okay. And there is an external component. Now that external component is called as audio processor. This audio processor is worn behind the ear. Okay. This external component or the audio processor will contain a microphone. That microphone, what is the job of microphone? It will pick up sounds from the environment. And it transmits those sounds across the skin by radio frequency waves to the internal receiver. Internal part has receiver and FMT and a connecting tube. So wait, I'll write that down for you. What is the entire mechanism? First, there is the external component or the audio processor that is present outside. Behind the ear, this is present. What does this contain? It has a microphone. What does the microphone do? It picks up sounds from the environment and it transmits those sounds across the skin. How is it transmitting? By radio frequency waves. To whom is it transmitting? To internal receiver. Okay. The receiver is connected to what? It is connected to the connecting link. There is a connecting tube, isn't it? I told you here. There is a conductor link. Yes. So, the receiver transmits it to the conductor link and the conductor link is connected to what? FMT, floating mass transducer, and floating mass transducer is in turn connected to incus bone. So finally our goal is achieved. We are sending the sound directly to the middle ear by all this system, bypassing the external ear. Is the mechanism of vibrating sound bridge device clear to all of you? External component, microphone, transmits the sound via radio frequency waves, and these radio frequency waves are picked up by receiver. Receiver sends it to floating mass transducer, and floating mass transducer is connected to incus bone. And then via incus it goes into the middle ear. Sound goes into middle ear. Now I'll show you a picture of how this entire thing looks like for further clarity. This is the external component. What is the external component called as? Audio processor. And it is connected all the way. Can you see something here? This small wire or something that I can call a conducting link. It is connected till the incus. Okay, this is how the system looks. I'll erase the annotations so that you can appreciate it better. Can you see it now? It's connecting the incus and the outside system. So this is vibrating device. Is it clear to all of you? Let us look into the candidacy profile. Who should be prescribed these direct drive devices? Number 1 is patients who are having moderate to severe sensory neural type of hearing loss, and they should be above 18 years, at least 18 years or older. Second, they should have already used the traditional type of hearing aids and they want to go for improvisation. Directly you cannot keep middle ear hearing aids. Okay, people who are using the conventional ones, because of certain problems, they will have some dissatisfaction and they would want to go for better devices. In them we can use this. Okay, because the middle ear, direct drive middle ear hearing devices will improve the sound quality. Okay. Now, why would somebody want to change from the conventional hearing aids to something better? One, see, the conventional hearing aids are present in the external auditory canal, so they will cause something called as occlusion effect of the ear canal. The patient will feel that the canal is always full. That's a uncomfortable sensation. Okay. Second, if they are having a lot of wax production, that can occlude the hearing aid mount. Wax can get impacted in the external auditory canal and then they cannot wear these traditional hearing aids. And some people will have skin allergy. Skin is sensitive to these devices, it doesn't go well and they always have these otitis externa because after all it's a foreign body, right? And also, as I told you earlier, this feedback issue, where because of all these things, the sound produced by the amplifier is retaken back by itself and it will cause those whistling sounds, beep sounds and all, making it uncomfortable for the patient. In all those people, we can use these. In patients who are dissatisfied or experiencing problems with conventional hearing aids. I told you what are all the problems, okay? Now let us see how this procedure is done. The internal device, it has to be surgically implanted. What we do is we give general anesthesia to the patient. What we do is we give general anesthesia to the patient and the internal part, that is the receiver, is positioned under the skin over the mastoid bone. How can we put this implant there? We can do a standard, I'll write this down for you. A surgery is performed. What is the surgery? Cortical mastoidectomy is done. Cortical mastoidectomy. And in this cortical mastoidectomy, via the posterior approach we go, we visualize the ossicular chain and then we put this floating mass transducer to the long process of incus. That is our aim of performing this cortical mastoidectomy. What we do is place the floating mass transducer to the long process of incus. The other middle ear structures, we don't touch them, okay, they are left as it is. So there is no impact on those structures or whatever residual hearing the patient is having, that is also not disturbed. After we do this procedure, 6 to 8 weeks later, what we do is we connect the external device, that is the audio processor. It is attached magnetically to the back of the ear and then it is all programmed. Okay, so this is how it's done. 6 to 8 weeks later, the external device is connected and programmed. What was the time gap for Baha surgery and connecting of the external sound processor? Time for osseointegration, it was 2 to 6 months. Here it is 6 to 8 weeks. Okay. What are the advantages of using this? This will provide mechanical energy directly to the ossicles. We are bypassing the tympanic membrane as well as the external auditory canal. So any inherent issues that are present with conventional hearing aids like discomfort, wax related problems, that fullness, feedback, all of them are overcome. Another major advantage is the sound quality that is produced is very good. There is improved sound quality, much better than the conventional hearing aids, and particularly in noisy environments. Okay, particularly in noisy environments. Good sound quality, particularly in noisy surroundings. So, is this clear to all of you? The middle ear hearing devices, implantable middle ear hearing aids. With this, I complete all the type of hearing aids. First, we have conventional type and then we have bone-anchored hearing aids and finally implantable middle ear hearing aids. With this, I complete hearing aids and then let us learn about implants in the next video. Implants and other devices. Okay. Thank you very much.